Okay, so this will be your first lecture on therapeutic interventions and introduction to therapeutic interventions. And again, at the beach, so I apologize for the background here. The objectives of this lecture should be for you to walk away with understanding basic definition of therapeutic intervention, understanding classifications and modalities, beginning to develop clinical decision ideas for use of interventions in patients when you get to those courses. So this is really going to start planting the seed, if you will, for future courses. And then understanding the evidence-based concepts of developing a plan for using therapeutic interventions. What is the therapeutic intervention? Well, it's really anything, honestly. It includes therapeutic modalities, which are things such as electrotherapy, ultrasound. In electrotherapy, you can break that down into interferential current, microcurrent, TENS units, all these different things that we'll discuss a little bit later on in the semester. It also includes rehabilitation or rehab and manual therapy of patients. So I think I feel like my expertise is within the manual therapy realm, especially Mulligan concept, which we'll hit later on in the semester. How to define a TI, which is therapeutic intervention. No true textbook definition, which is kind of crazy, right? Definition we're going to use for our lecture is therapeutic. Okay, well, we know therapeutic pertains to results obtained from treatments. We know it has medical or healing properties, and it could be a healing agent. Now, if we look at the second part of that word, modality, is a method of application or the employment of a therapeutic agent, limited usually to physical agents and devices, but any specific sensory stimulus such as taste, touch, vision, hearing, or pressure. Putting it all together, you notice that right here, therapeutic modality, which could also be an intervention in our case, is a device or technique that delivers a physical agent to the body for therapeutic purposes. There's truly a mixed approach with modalities and rehabilitation techniques. You'll notice as we go throughout the semester, I will hit a lot between modalities. There's just a lot of crossover between modalities and rehab techniques, and I think that's a big reason that George Mason set up their courses like this, is that I gave you the basic foundational knowledge, and then in future courses you will have lower body eval and go over how to treat an ankle sprain and how to do this and that with a different modality or rehab technique. But if you don't understand those basic principles first, you can't put it all together. Examples of physical agents that we'll actually use in the hands-on portion would be heat, like a hot pack, cold, like an ice pack, right? Light, electricity, such as TENS units, interferential current, anything that's plugged into a wall, essentially. And then therapeutic exercise. Reasons we may use therapeutic interventions would be for wound healing, and we do some with wound healing. You see wound healing a lot more in a hospital-based setting, inpatient-based setting. We definitely use interventions for pain relief on a daily basis. Same thing, flexibility, range of motion. On a daily basis, we're working for decreasing the patient's pain, increasing flexibility, maybe increasing strength and endurance. And as the rehab process progresses, you'll see you may want to increase muscular speed, increase or improve coordination and skill, power, agility, and even cardiorespiratory endurance. You notice I keep saying patient. Words you will never hear me say would be athlete, unless I slip and say the A word. I always say patient. You will never hear me say trainer. I will never say trainer. We're athletic trainers, right? You'll never hear me say training room as well. It's either athletic training facility, athletic training clinic. Big slide here, classifications of modalities. So you can break down the modalities into specific classifications. So here we have like mechanical. A mechanical modality might be a massage, or joint mobilization. US would be ultrasound and whirlpools. Cryotherapy, which is essentially ice, right? Ice packs, ice immersion, ice massage. Ice massage is no fun. No one likes that. Same thing with ice immersion. Who wants to put their body in 36 degree weather, 36 degree whirlpool or immersion to make it feel better? That's just counterintuitive to me. Thermotherapy would be like a moist heat, diathermy, an ultrasound. Ultrasound can be a little tricky. Ultrasound actually can be mechanical or thermal. If we do mechanical ultrasound, that means we're doing it on a non-thermal mode, so therefore it does not fall into thermotherapy, it doesn't produce as much heat. Hydrotherapy could be a contrast bath, aquatic pools, electrotherapy again, and then the manual therapy, many different types. You notice I put Mulligan concept and positional release up here. These are two that we'll end up going over throughout the semester. And of course, exercise. Art versus science. So the art is influenced by experience and tradition. So modalities is an art, and rehab is an art, and I think AT is an art, but you also have to have the basic science skills. Right, so the art of therapeutic intervention would be its influence from the experiences you as a clinician, tradition maybe, and then what the research evidence is saying. So science, there's a lot of I guess, lacking, glaring holes in literature of modalities research. I think you guys as master's students and even undergrads in the course will get a better basic science background than maybe even I had. That's a big push in athletic training education to make sure everyone has good basic science skills. There's some supporting intervention or evidence for rehab interventions, but there's a lot of lack of supporting modalities. A lot of lack of evidence, big lack of evidence. So traditions, old versus new. Well, I've been around some athletic trainers, even physical therapists, that you have an ankle sprain, we're going to put you in a nice immersion right away, even though gravity is going to take all the swelling and all the exudate that we'll learn next chapter, and make your ankle fat, if you will. Versus new, we know not to do that. We're going to talk about ice later next probably 2 weeks, and we're going to learn why ice is not good for you. Why I think ice actually does absolutely nothing for you except dull the pain. It will not get rid of swelling. So the new evidence-based articles, some of which you'll read from the NATA, the National Athletic Trainers Association, put out a position statement on like best practices in ankle sprains, and it grades at A, B, C. So A would be the best evidence, the C would be the least amount of evidence. Number one, A, you need to move it, compress it, and ensure that you don't just ice it. Knobology, I love this word. The study of application without basic theory or knowledge. Not only in therapeutic interventions, you'll see athletic trainers out there that have no idea what to do. Pretty much in therapeutic modalities, this means that if you've never seen a modality, you'll see them later on when we're on campus, but you go into the athletic training facility, there's a modality sitting there. Turn the button on, you push preset 1, you turn it up, hit start, walk away. That is a knobologist. That takes no scientific thought whatsoever. As long as you know how to push the buttons and where the power button is, you can use a therapeutic modality. Do not become that person. Do not become that professional. Don't become a knobologist, right? Every patient's different. You need to make sure that you take into account the best evidence, what that patient actually has going on, their values, and your prior experiences with that specific pathology or injury for them to improve. And that really is right here, clinical decision making. Right now, you all are young, if you will, in the athletic training profession. This might be your first athletic training course you've ever taken. So you really don't have that clinical decision making skill yet, but you will develop that pretty fast. So this is the process of determining how to treat patients. Tradition, the way it's always been done, handed down from the athletic trainers that are maybe retiring. One of my friends in Louisiana swears by every ankle sprain he puts in a brown paper bag soaked with vinegar, and that takes away their pain and swelling. How that works, I have no idea. Honestly, physiologically, I have no idea. But this is the way his athletic trainers that he learned from and back in the day have always done it, and that's been handed down. As a profession, we're kind of getting away from that, if you will, because there's better research coming out. Experiences, successes, and failures with similar patients and conditions, you're not there yet because you probably haven't treated any patients yet, right? But as you develop your experience and see, 4 or 5 ankle sprains in a week, or I don't know, 3 or 4 ACLs in a semester, you'll get better and better at improving that patient's outcome. Research, scientific investigations into the unknown. There's a lot of research out there, but unfortunately not a lot in a therapeutic modality. There's more on the therapeutic intervention, if you will, like Mulligan concept. I've written a couple articles on the Mulligan concept. I know a couple people, George Mason, have as well. But there's a big push in the profession to show our outcomes and make sure we're actually improving the patient's pain or doing what we're actually saying we're doing. Right now we don't have any evidence that that is actually occurring, right? So theory would be the last one. Best guess what's going on based upon evidence and experience. So selecting a modality for use on a patient, whose decision is this? This depends on the State Practice Act. Most physicians really do not understand therapeutic modalities. Still, you'll see a script maybe written out, and I think I have that. I actually don't have that the next slide. So we'll get to that in a second. Most physicians really do not understand therapeutic modalities. So in most times, in traditional settings, it's the athletic trainer, right? Figuring out, okay, I have a patient in front of me with a 2-day-old ankle sprain. What can I do to decrease their pain or swelling? In outpatient clinical settings, most times you will receive a script from a physician, right? And on that script, it may say, patient with LBP, low back pain, eval and treat. Well, that's not a lot of direction from the physician. I've actually gotten these scripts from physicians before that they may even say, patient with patellar tendonitis, use ultrasound. Well, that might not be the best modality for them, but depending on the State Practice Act, you may actually have to follow what that physician is saying. I honestly do not know the State Practice Act in Virginia anymore. I was employed at Christopher Newport University in Virginia for 2.5 years, and it's been years, so I don't know the State Practice Act anymore. Selecting the proper tool, modality, exercise, therapeutic intervention, kind of lumping them all together, right? You have to have a proper diagnosis. Well, you're not necessarily there yet because you may not have had eval class yet. But you may have a basic scientific and physiological understanding of the healing process. At least you should after I get done with this course, right? If I do my job properly. Know what you want to accomplish with the modality. What is your goal? Talk to that patient. What is their goal? If they're a 90-year-old grandpa, do they want to just be able to walk up and down the stairs or take a shower by themselves? That's a goal. Now, athletic trainers may not work with that age population very often, but even in the athletic setting, you have to know what that patient's goal is. Do they want to go back and play their sport even after traumatic injury? Does that therapeutic goal match with an intervention that you can do that will help you achieve that goal? And there's so many different interventions out there we'll talk about. And understanding the different modalities, effects, indications, and contraindications. So an indication would be, yes, this is why I would definitely use this modality intervention on a patient. A contraindication would be, I do not want to use this use this modality on any patient. Most times contraindications would fall under okay, I'm treating a female that is pregnant. A lot of electrical modalities and certain things we cannot do on a pregnant female. Even cancer we cannot do a lot. Like ultrasound we cannot use with metal, right? So if you have any metal in your body, we cannot use ultrasound on you. And that stuff will hit with each modality. Rehab plus modalities equals interventions. Well, yeah. Our book talks about 4 basic misconceptions that there are out there, that you treat injuries and then you rehab them. Well, no. So you have your star basketball player that sprained their ankle tonight at basketball practice, and they're starting their next game's tomorrow. Well, you don't treat that injury on the court and then you rehab them. No, you start treating that patient as a whole right as soon as that patient gets injured on that basketball court. Because if you don't properly manage that injury initially, you'll learn in the next chapter you're going to have exudate and swelling and all this stuff that we could control, secondary injury essentially, that we could control initially. And if you don't control that initially, they're going to be worse off later, right? Rehabilitation is reconditioning. They're different. Rehabilitation would be, improving the patient to get to that point of reconditioning, or work hardening, it's sometimes called. Working with weights. I pick things up and put them down, right? No, we're not personal trainers. We're not strength coaches. I don't work with weights. I really at all, honestly. And then the cookbook approach. Not every ankle sprain, ACL, not every injury should have the same exact treatment. I'll repeat that. Not every ACL should follow the exact same protocol. I might get in trouble for saying this. Every time I've worked with an ACL patient, the doctor gives me the protocol that we'll talk about. I actually rip that up usually, and I treat the patient how they need to be treated. The doctor is trying to give me a basic protocol for a reconstruction of an ACL that may not fit with my patient, you know? So that's part of the evidence-based approach. So do not fall into that cookbook approach. Don't do it. You can tell I'm passionate about this, right? Every patient's different. Yes, you're going to have some similar exercises depending on what healing phase of the injury they're in. You may actually have the same modalities at certain points. But not every single athlete should be following the exact same everything protocol, right? For their injuries. This may actually take them longer to improve. This will actually probably hurt your patients more than help them. It may hinder them more. And some of this is going to be a little psychological as well. The psychological factor of getting over injury can be pretty great. So we talk about the systems approach. You must have a basis for choosing your modality, understand your goal, what you want to get out of using this modality, and the patient's goal. Are you putting ice on them because they're in so much pain that you can't palpate, touch them at all, right? To evaluate them, well, yeah, here's an ice bag. Let's put this ice on you. Let's numb up your superficial nerves, and then I can do my eval or proceed with my whatever it is, right? And what are the patient's goals? Are you trying to train them to be an Olympic, skier when all they want to do is be a recreational skier, go to the mountain every couple days? All right. Is there evidence, and what does it say? What are the patient-reported outcomes on a given intervention? Is there evidence out there on the intervention you want to do, and is it bad? Is it good? You'll see for a lot of the modalities, there's not a lot of research evidence out there. Yeah, I'll leave it at that. We'll hit that a lot more, right? Preparation for this for the use of modalities. Be an active learner. You need to take a proactive approach in learning modalities because it can be difficult to understand. Understanding basic science concepts that you can tie to each modality. Be skeptical. It's definitely okay not to believe everything you're taught. I agree. I don't believe it. Be skeptical. Question me. Not too hard though, but question me. Question. Research. If there's only one research article out there saying that this intervention works, it's the best thing since, I don't know, sliced bread, don't just rely on that one article. There needs to be more cooperation, right? So, yeah. So, that is then to chapter 1, Therapeutic Interventions Introduction. It's pretty much an overview of the semester, a little bit of what a therapeutic intervention is. So the next lecture will discuss pathomechanics of healing and really trying to nail down some basic sciences of, okay, this is what happens when I do sprain my ankle or tear my ACL or dislocate my shoulder. So this next lecture will be a little more in-depth. You'll have a discussion board. You need to go on to the discussion board 1, I believe it is. It'll be on the left-hand side of the screen there. Click on that. There's a bunch of questions to answer. You need to do that before next Friday, which I believe is July 1st. by 5 o'clock. So please go on to Blackboard and try to answer some of those discussion board. Everyone should answer at least the initial discussion board, and then go in and talk to each other, ask each other questions within there, debate. Don't argue, just debate. It's healthy, it's good. All right, guys, till next time.